Okay, thank you. Sorry, we got off to a little bit of a late start. We had to sort out some technical details, but here we are. And so we might as well dive right in. So thanks for coming. I am Sherry Pagato. I'm the director of the UConn Center for mHealth and Social Media, and super excited to be here today to introduce our special guests. And give me 1 second. Sorry about that. Let me do the introduction. So today we have Dr. Kate Wolin. She is a behavioral epidemiologist and entrepreneurial executive. After a successful academic medicine career leading research at the intersection of behavior change and chronic disease prevention and management, Dr. Wolin co-founded and led a digital health startup that was acquired by Anthem. In her subsequent roles with large and small companies, she has worked to bridge research-tested health solutions programs and commercial scale. For some background, she earned her doctorate at the Harvard School of Public Health, completed her fellowship training at Northwestern University, and she currently mentors aspiring healthcare entrepreneurs at the University of Chicago and Northwestern University. And so she is here today to tell us about who will use it, choose it, and pay the dues for it. So Kate, take it away.
Thanks, Sherry. I'm really excited to join you today after having attended some of the center's talks in the past. I know I have some big shoes to fill, and really excited to get to talk about, as I've left academia, some of the ways of thinking about problem solving in healthcare, and things I've learned that have shaped my thinking a little bit differently. And so one of the things that tends to come up a lot is sort of the language that we use and how different groups communicate. And one of the things that I've been really excited and happy to see is that whether it was back in my training in public health, which is more years ago than I care to tell you today, when we talked about community-based participatory research, or the current conversations happening in medicine around patient-centered care, or going over into the design world where we talk about user-centered design. In all of these ways of thinking and approaching problem solving, we're putting the user at the center. And I think it's really, it's a great thing to realize that while we might use different language in different disciplines and sectors, we're all centering what we do on the empathy for the person or the patient or the user or the customer, whatever word we want to use to describe who's at the center of what we do. And I think that that's a great anchor point to move from, because it really helps us realize that when we're thinking about users, lots of different groups put the user at the center of what they do. And that shared mindset is a great thing to anchor on, even if the language we might use is a little bit different. So in healthcare, we're going to refer to that person often as a patient, even if we're not actually in a hospital or healthcare setting. One of the folks I work with says, my goal is to keep everybody out there, my customers, from becoming patients. So patients within our healthcare worker are often the phrase that we use to describe a user, whereas in the business world, we might be talking more about customers, but same kind of idea there. And then as we sort of go into that, I mentioned that we sort of put the patient at the center of our thinking and our problem solving. And one of the things I think it's really important is that we start with a problem, and that patient's problems anchor what we do. And so this means we're not going into our approach with a feature set that a feature that we want to add to an app or a product that we want to sell. We're going in there focused on that patient's problem. And so it's really thinking about the why of what we do instead of the what that we do. And so this quote from Charles Rebson, which, if you haven't connected the dots yet, is the founder of Revlon Cosmetics, I think is a great example of what this can look like in different places. And in the factory, they may make cosmetics, but their why is selling hope in the store. And so it may make Revlon sound a little more aspirational and help centered than many folks think about it. But if a company like Revlon can center cosmetics, around a why, than certainly much of what we do in healthcare can. And I think it's important to put that why and that patient problem at the center of all of the work that we do. The other place that there's a lot of overlap between what happens in different disciplines in the commercial world and what happens in our healthcare, our research, is that having this test and learn mindset. And so we're going to iterate and we're going to evolve what we do. And so we might call that in an academic research lab with a faculty mentor like Sherry, we might call that a pilot project or a pilot study. And we might use different language in the commercial world, like a prototype or an MVP, which, if you haven't heard before, is not a reference to whether or not Michael Jordan or LeBron James is the GOAT, but it's actually a reference to a minimally viable product. So the smallest, most simplistic thing that you can launch to test what you're trying to test and get the feedback that you're looking to get. And so that also anchors us in having a common way of thinking across our transition as we move things from academia and our research settings into the commercial space. So in sort of thinking about how this might be approached, and I think a lot of these are things that happen in different sectors, but sort of laying out a process here and thinking about a common framework that centers us on the patient as user, I think is helpful. And the first is how we frame up what we're doing. And so I mentioned sort of starting with our why, and that really goes into how we frame what we're doing and making sure that that framing during our ideation is centered on the patient and their why. And so implicit in this is that we're starting with ideation, and our ideation is not around solutions, it's around problems. And being as specific as we can in that. So saying that we want to improve the lives of children or patients is a fairly vague statement. And we want to work through our ideation of our problem framing to get more specific. So saying we want to help oncology patients is more specific than saying we want to help patients. But as we work through our ideation around our problem statements, we're going to get more specific. And one of the ways that we do that is to use our hunches. So we all have hunches about what our solutions to the problem might be. And we also have hunches about what our constraints for solving those problems might be. And so as part of our ideation process, it becomes important to articulate those and to talk about what they might be and to, kind of add layers to it. And so it allows us to move forward. And this is not hypothesis generation for the purpose of testing in our trials or our research. We're really still in the ideation phase around our problems. And so that allows us to reframe and get more specific. And so this might be where we get more into, how might hospitals delight oncology patients? And so using adjectives to really push our thinking and our ideation. Or it might be something like, how might we eliminate waiting at hospitals altogether, right? So challenging assumptions in the status quo. So our ideation here is really about how might we frame the problem in an innovative way that really centers it on what is frustrating, challenging, or helpful to our patients. So centering it on their why and their problems. And the way that the tool that we often use in the commercial world that to do this is to think about framing our problems centered around three things that are really important to a patient. So we all have jobs that we're trying to do. We have pain points and we have wins. And so we want to get specific about what those are for so it's customer here, because this is a tool used from Strategizer, used in a lot of commercial work, but patient can drop right in there just as easily. So the key thing here is, one, this is centered on the patient or the user. And then we want to get really specific about it. So if we're thinking about that waiting room example, right? A pain point is not sitting in the waiting room. A pain point might be waiting more than 5 minutes to come into an exam room is a pain point, right? It's got some specificity to the when and the how long and the what. And so, getting that specificity here in terms of our pain points is helpful. And when I first saw this, I thought jobs to be done, and I thought jobs were tasks, right? But they're not just tasks. Jobs are problems. And so we can actually think about different types of jobs. They can be functional, like a task, right? I need to mow the lawn. I need to write a report. I need to submit that grant. Um, but they can also be social. So I want to, as a patient, I want to be seen as a good patient. I want my doctor to like me. And they can be emotional, right? How a patient is feeling. They're anxious about losing their job if they are out of the office too long for this appointment, right? That their boss is going to get frustrated because they thought you were only going to be gone for an hour and now I've been gone for 3. So there are a lot of functional, social, and emotional jobs that a patient might be navigating in a clinic. And so thinking, when you're thinking about the framing for your problem and the framing for where your patient is, thinking about not just tasks that they have to do, but also the social and emotional jobs that they're trying to accomplish and what might be pains and gains that they might experience in those. The other thing to remember is that not all jobs are created equal. So for those of you who were born after 1977 and don't know what DEC is the Digital Equipment Corporation, and they were the leading computer company for a very long time. And if you're interested in innovation and how companies and organizations innovate, there's a great book called DEC is dead, long live DEC. You probably can only buy it used at this point. But the company founder and CEO, Ken Olsen, really staked his claim on the fact that having a computer in the home was not a job that people wanted to accomplish. It was not a pain point that they needed to solve. And so I think it's important to remember that jobs can change and they can change really quickly. So, my personal lived example of this is that, when I was a baby research assistant in grad school, I had this really handy device called a Palm Trio. And I would bring it to all my meetings and I would log my calendar. And some of the folks I worked with said, I don't see the need for that. Like I have my paper calendar and it works just fine. And a number of short years later, I transitioned and upgraded. I was really excited to move from my Palm Trio to my BlackBerry. And here we are, RIP BlackBerry. And so what people consider a nice to have and a need to have can change very quickly. And so one of the things that it's helpful to do when we're thinking about the jobs that people are trying to accomplish or the pain points that they have is that they can be different in different contexts. And they can change over time. And that way of thinking in terms of the commercial world, I like because it really aligns with a lot of the behavior change models that we have in behavioral medicine and health psychology that really anchor our work in the family, social, community, organizational structures that people operate in. And so it's great when you can find these parallels and realize that in both situations, the importance of a pain point or the challenge that someone has can change depending on timing and context. And so it's a great place where having that shared mindset can help us. And that really, to me, is a great thing about when we have diverse teams, right? So we know the research that having a diverse team matters, and diversity can mean lots of different things. So one of the very first projects I worked on coming out of my undergraduate studies was actually on a waiting time quality improvement project at the Dana-Farber Cancer Institute. And we had all these high-level people, senior executives and physician leadership working on how do we reduce waiting time for patients, because it was the thing on the patient satisfaction surveys that kept coming up as the most frustrating for the patients. And there were all of these technology solutions that had been put forward. And one day I was waiting for the leader of the clinic and was chatting with the person at the front desk of the clinic about why I was meeting with the physician leader. And she said, "You know what we need? We need more pens." And I said, "What do you mean?" And she said, "Well, the thing that keeps someone sitting here and waiting is that they have to complete this paperwork." Remember pre-COVID when we completed paperwork on a clipboard with a pen? And she said, and a lot of times, I don't have any pens to give someone. So then they've got to find a pen or they have to wait for someone else to finish using a pen and they can't complete their paperwork. And I can't send them back to the room until they've completed their paperwork. So sometimes we're just waiting because we need to complete the paperwork and I don't have any pens. And I thought to myself, my goodness, we're sitting here talking about re-engineering physical spaces and moving walls. We're talking about building technology solutions. And here someone's telling me I could shave 2 to 5 minutes off the waiting time if I just went and bought a $2 box of Bic pens down at CVS. And so it's another level of having, people across the process that you're looking and the problem who see problems from different lenses that matter. And I think this is another place where, whether you're doing public health and doing community-based research, or you're in user-centered design or patient-centered research within medicine, we all want to have different folks from different places within the problem weighing in on what we do. And it gives us a different lens on what that patient is experiencing as we anchor our work around that user and their experience. Now, of course, as a scientist, at the end of the day, research matters. And so whenever I can, I'm going to reference Bayes because it's one of my favorite parts of science. So this is where I call it's time to put on your Bayes hat in the research process. And so those of you who've studied it know that one of the key parts of Bayes' theorem is using your known priors. And so to me, this is the part where we go to PubMed, we go to PsycInfo, and we pull up what we know from previous studies. And it's a great thing to be able to lean on that. And you can really see it in a solution when someone has ignored the previous research, right? When they take their N of 1 lived experience and they try to turn an anecdote into data. And when someone has gone and said, okay, there's 30 years of research in health psychology on weight loss, so my hypothesis about what's going to work maybe has some context that I can add to it by going to that literature. And so this is where we start to build out what might be called a mental model or a framework in the commercial world. And we're going to start to pull in our theories of behavior change and behavioral medicine. And our theories here are necessary, but they're not sufficient as far as sort of our process for thinking about solution development here. So using our known priors is a great first step. It's a place where we anchor our research and our development cycle. But at the end of the day, we have to get out of the building. And as an introvert, I love to sit in my little bubble here, but we have to get out of the building. We have to talk to community members. We have to talk to subject matter experts, right? I think one of the things that was sort of most interesting to me the first time I went to a conference was realizing how much the scientists whose papers I had admired knew that never made it into a research paper, right? So interview those subject matter experts. And when we choose people who to talk to, right? Our patients, our community members. I think sometimes there's a temptation to find the representative person, right? The person who sort of sits in the middle. But this is a place where we want to get to go from Bayes not so cool to my icon, Billy Joel, and go to extremes, right? Find the extreme users, find the person who is still rocking a flip phone and ask them how they solve problems if you want to build a technology. Go talk to the patient who has 6 chronic conditions, not the one that you're interested in solving for. Those extreme users are going to help you understand your problem. And when you talk to them, remember that you're not there to say, here's the solution idea that I think I have. What do you think about it? Because, for the most part, people are really polite and they're going to smile and nod and they're going to say, yeah, that sounds like a good idea, because they want to be nice, right? You're there to talk to them about the problem. Tell me about this. Tell me about what your problems are. Tell me about your experience. And in that, you will learn things that you wouldn't have otherwise learned because you're there to listen, right? So it's really sort of taking almost your therapy, therapist hat if you're a clinician, and thinking about it. The other place that it can be helpful to look is to analogs. So as someone who's worked in behavior change for a long time, I feel like I can't open something to read. I can't go on Twitter without hearing someone tell me about their solution for habit formation. They're very popular and they're very buzzy. And that's great, because it would be great if we could turn everything into a habit that was happening with subconscious processes. And that's great. And we did that ourselves in a lot of our work. But it's important to look at, like, what are really the habits that people have, right? And so the one I kind of always anchor for myself is around toothbrushing, right? Like, for most people, or goodness, I hope the people that I'm sitting next to the next time I go out in public and sit next to people someday, I hope, is toothbrushing, right? We want people, we hope that the people, we know most people, they're brushing their teeth every day. And it's something that we don't create a plan for. I don't have to put a calendar notice in to remind myself to do it. It's just something that we do every single day. And so using analogs, when I'm working in weight management or other behavior changes like toothbrushing, can be a helpful framework. There's a great example of a hospital emergency department, and they were looking about how can they improve the process of moving people from from surgery into the ICU, right? So not the emergency department, but the surgery department rather. And that process involved a lot of people. It involved complex machinery and a lot of things happening at the same time. And they wanted to increase it because they were trying to improve patient safety and reduce the errors that were happening. And the analog that they looked to was the Ferrari pit crew, right? So if you've ever watched car racing, you know that when a car is coming into pit at a racetrack, there are a dozen, if not more, people sort of in this ready, standby, like athletic crouched position. And they each are doing one very specific thing. And that is their task. And they are going to execute on it with precision and just incredible focus. And so it created a great analog for actually what happens in that transition from surgery to the ICU. And so our analogs don't just have to come from other health behaviors or healthcare settings. We can often learn from looking outside. And again, it's a place where our diverse teams can be really helpful. And so having someone who doesn't have a healthcare background and can ask those sort of like, well, what about this? And why haven't we thought about this question, right? Those extreme people can be really, really helpful when we think about the process, because sometimes we get so focused on what we know that we just sort of unintentionally don't see the things that we don't know. So then I think we get into this place of we want to start thinking about what people have told us as we have these interviews, we have these conversations, right? And what turns out, and we know this from a lot of other settings, but we sometimes forget it when we're doing our ideation and user research, is that what people say they want and what people want are not often the same thing. And it's not that people are trying to mislead us or they have, misperceptions about things. Sometimes the context is different. Sometimes, there are competing demands that they're not aware of. So an example of this maybe that folks in the prevention world is that we hear from people all the time, I don't have time to exercise, I'm very busy. And on the one hand, that may be true. But when we go and we look maybe at a third-party data source like the American Time Use Survey, what we see is people have plenty of time to watch television. They have plenty of time to do other things, right? So it's not that they just inherently don't have time. It's not that they're working 20 hours a day and sleeping the other 4, which would both be a bad idea. From a health standpoint, but that people are prioritizing, they're using time differently. So this can be a place where it can be helpful to actually observe people in the wild, right? So put your anthropologist hat on instead, and go observe people in context. Sit in a clinic and watch what happens. Ask people to tell you their story. Have them journal, use photos, have them role play, right? These are great places to learn about what someone's problem is like. And if, of course, this happens in industry a lot. One of the quotes that Steve Jobs used to throw out all the time came from Henry Ford, right? If I had asked customers what they wanted, they would have told me a faster horse. And so if you ask people what they want, sometimes it's quite constrained by what they know. And part of the fun part of innovation and problem solving around users is to give them something they didn't even know was possible, that hadn't occurred to them, which is, of course, what RIP BlackBerry happened around our smartphones. So I sort of keep saying that we're all focused on the problem. And at some point, right, you do have to move from talking about the problem to thinking about solutions. And so this is where we sort of move into our ideation, and a place where obviously, being with a group is going to be so much more powerful than sitting in a room and ideating by yourself. Our science of team science is really important here, and also kind of similar parallels exist in the commercial world. So we want to have a way of sharing what we've each learned when we're going out and having conversations and observing in the wild. Look for themes that people are seeing. Document the ahas and the this surprised me. Right? We don't want to lose our extremes in this process and focus on the middle. So think about people documenting, right, their top five, and there are some really cool, and in the pre-COVID days, we might have done this in a room with a whiteboard and post-it notes. We might do it now with mural, but there are lots of ways that we can share and ideate. Particularly when we try to work with teams that may be in different universities or different organizations, and we want to collaborate. And so there's lots of ways that you can kind of take that and summarize. So it might be that everyone ranks their top five, and we use dot voting if we were in a whiteboard room. But the other way that sometimes we can do this that I think is helpful is when we put together a journey map, right? So we might want to have someone walk through their day and document the things that happen along the way. So in a patient journey, right, this might be that we anchor it around some of the pain points, right? Like how difficult it is to find parking at our hospital, that there's no Wi-Fi in the waiting room, and I can't check my Twitter feed to engage in my daily doom scrolling, right? So these are tools that we can use to center our ideation around the patient and their journey. And we might shift from realizing that we thought the biggest pain point was at day, 4, but really the biggest pain point is at day 24, and we want to change that. So change where we kind of focus our efforts, and narrow in on that process. And then we get to the point of thinking about how are we going to solve this problem? What problem do we want to solve? And how do we want to go about solving it? And I think particularly in the technology world, this is a place where it can be really tempting to say, okay, I got to go find a developer. And as much as I love every time I have the opportunity to get on the phone with Jeff Cohen and talk about what I want to build, what I've learned over days is it's much more helpful when I get on the phone with my favorite developers if I have a more concrete plan of what we want to build. And one of the best ways to get to that is by using a prototype. And your first prototype doesn't have to be, let's write some crappy code and then see if it works. There's lots of ways to prototype. So you can write out a storyboard where it's like a cartoon, right? Like you're writing a comic strip of what's going to happen. If you're thinking about you want to enhance a piece of technology, so my wonderful esteemed colleague David Conroy has a water bottle that measures when people are drinking, right? So you could take a water bottle like this and you could attach a device on the bottom and you could observe people using your prototype. If we want to deliver people healthy meals, right, we can do that with a cardboard box and some magazine cutouts. And even if you're certain that what you need is a technology solution and an app, you could actually do that with cardboard and paper. And you can show the different screens and what will happen. And it allows you to think through the flow and whether this is something that's, you thought was going to take 5 minutes, and it actually takes someone 25 minutes to get through. And now, before you've gone out and you've hired someone and you've written a line of code, you understand what that experience would be like for a user and where there might be friction or frustration or opportunity that you maybe didn't see. And so that's a great sort of way to sort of think about your user's experience, again, before you go out and actually write a software application or build an app or whatever it might be. And so we think about the user in all of this. I've been talking about the patient as the user. And in entrepreneurship, we talk about healthcare as being the double black diamond of entrepreneurship. And so the reason is because the patient isn't our only user. So when Airbnb wanted to rethink travel, The person who's searching for lodging, buying lodging, and staying is me, right? I'm the user in each of those three key parts. Now, maybe with corporate travel, it's a little bit different, but for an enormous amount of travel, the user doing the three key steps is the same. But in healthcare, it's different. The patient might be taking that prescription, but the doctor is the one who's choosing the medication, and the insurance company is the one who's approving that it gets paid for. So the person who uses it, the person who chooses it, and the person who pays the dues on it are different. And that means we actually kind of have three users that we have to think about when we're designing healthcare solutions. And oftentimes, when I was training and I was doing things as a population health scientist, I might have thought of two of them. Typically, I was really focused on one of them. But by not thinking about all three of them, I missed the opportunity to build solutions that could leave the lab easily. So lots of things can leave the lab eventually, right? But we're all trying to sort of shorten that well-known 16-year pathway from idea to implementation in the real world. And there's a lot of steps in there, but by thinking about all of our users, we can actually possibly accelerate that process. And so I thought it would be useful to kind of walk through the example from our startup scale down, and be really transparent with you about some of the mistakes that we made along the way, or things that I might have done differently had I had this mindset at the time, and hold myself, not my co-founders, fully accountable for all of those things that I should have thought about and didn't. So let me give you an overview of scale down and then kind of dive into that. So first thing, remember dinner parties, weren't they nice? So one of the things too is actually interesting is that video is a great prototype, right? It allows you to give people a sense of what your application and your solution is going to look like, and get feedback on it before you build the whole solution. And you can actually, you can tell that we made that video, right? We hadn't worked out our packaging yet for the solution. We actually ended up using a different scale when we went to market, but you can get a feel for what the program is about and the why of it when you watch that video. So videos are also another way to prototype. So the focus of Scale Down came out of Dory Steinberg and Gary Bennett's Weigh study, which showed that daily weighing was an effective strategy for weight management. So that sort of came from this idea around habits, right? And so when we look at something like brushing your teeth, and why that can be a habit, but why people really struggle, right? We know that self-monitoring is a cornerstone of weight loss, but we also know that people really struggle, right? No one comes in, for those of you who didn't start your careers before technology, we used to give people a pad or a notebook or something and ask them to log their food. And we would give them this book called Calorie King, and they would log their food. And we tell them to log their food every day, right? And then look it up for your calories and do a calorie count. And I think everyone who worked in that time talks about watching people complete the food diary in the parking lot before they came in, because no one actually filled it out like you see it on this slide, right? It was empty. And even here, you can see information is missing around portion size. If someone's, not including the milk they put in their coffee. We used to see this all the time. And so we thought that having apps was going to make this easier, right? That people are going to comply. But when you think about a habit like toothbrushing, which is truly a habit, and something like a food app, right? Like finding my phone, remembering to pull it out when I'm, completing a meal, like scrolling through, oh, there's my dog, to log my, everything. Like that is a really different set of behaviors. And it's a set of behaviors, which is really different from brushing your teeth. So what Gary and Dory really realized in the Way study was that if you can focus people on a discrete single behavior that they only have to do once a day, we might get closer to the habit formation that we're going for, much more like brushing your teeth. And so the trial asked the question, could you ask people to weigh themselves daily? And could you give them feedback to that? And not ask them to track their diet or activity and see weight loss. And the Way trial found that people did achieve clinically meaningful weight loss comparable to more intensive programs. And so that finding was the scientific premise, the hunch and set of hypotheses that went into scale down, right? And so we took that idea and we said, okay, the other thing that we know is we get feedback loops, and those are really important in habit formation. And so when we brush our teeth, right, one of the ways that we get that feedback loop is that minty, fresh taste in our mouth that comes right away, right? That's how we remind ourselves that we completed it. And so we created a set of messaging. So someone would get that text message that you saw right away after stepping on the scale. And so we designed that. We also thought in terms of our behavior change model that we wanted to create self-efficacy, and that self-efficacy was really important, right? That people felt delighted and empowered, that they had the sense that this is something I could do. So we focused on small behavior changes, but we also wanted it to, again, be this really low friction experience. And so one of the choices that we made, we actually did some early prototyping with a Wi-Fi scale, and we found that people got really frustrated. It took some of our users who were not particularly untech savvy, right? They weren't extreme users that had never engaged with technology. They were actually fairly middle of the road. And it was taking them 20 to 25 minutes to set up their connected scale. And that was really frustrating. And so at the end of it, they were not excited to go on a weight loss journey with us. They were not feeling a sense of like, I can do this, I got this, I'm ready to go. They were feeling frustrated. And so we switched over and decided to use a cellular scale. And that allowed us to pair the scale with the user's account at the warehouse. And so when it arrived, as you saw in the video, they take the scale out of the box, set it on the ground, step on it, and they would get a text message right away. There's no device pairing involved. It was a low friction experience, which was great. The problem with that was, in our efforts to lower friction, we didn't ask people what they weighed at onboarding, because we were trying to make onboarding as short and easy as possible. And we said, well, they're going to step on the scale and they're going to weigh themselves. We're going to know what they weigh. Why do we have to ask them at onboarding what they weighed? But it turns out that what we did not appreciate and anticipate in our user-patient journey was that everyone in the family might be excited about the arrival of this new scale. And so if you've ever worked with weight loss patients, or you've ever been on a weight loss journey yourself, and my guess is your experience is not all that different than mine when I'm trying to lose weight, which is that there is no way I am getting on the scale after I have had a long day at work, and maybe we went out for Chinese at lunch because it was Joe's birthday. We weigh ourselves first thing in the morning after the morning void, and typically with little to no clothing on, because we're trying to get that number as low as possible. So when our users came into the program, came home from work or school or whatever it might be, the UPS guy had delivered their scale, they took it out of the box, they set it on a hard surface in a place like the bathroom, like we recommended, and they waited until the next morning to step on the scale. but other people in the household didn't. And so we had set our logic to say that the first weight the scale receives is going to be the anchor weight that all of our logic and messaging will flow from. And we did not anticipate that a bunch of times in a bunch of households, the first person who stepped on the scale would not be our user. And so when we started out and we had a few hundred people on the platform, that was easy to solve, right? They would call or email or text into our customer service team, and the rep would say, "Oh, like, I see we've got a bunch of weights here. Like, do you weigh 185?" And the user would say, "No, that's my husband. I weigh 165." And they would see what had happened, and they would manually reset the system to use the 165 set of weights and ignore the 185 set of weights, and everything would proceed. And that worked fine when we had a couple hundred people on our platform, like I might have had in one of my studies in academia. But as our program grew and we went from having a few hundred people to a few thousand people to putting a few hundred people on the platform a day, that became a really untenable solution, because we basically had a full-time staff person who was doing nothing but that. And so we ended up re-engineering the solution to solve that. But I think had we done a lot more observation of users with our solution in the field before we had launched, we would have seen that play out, and we would have been able to build in the context around our patient into our journey, which was something that we didn't do. So the next couple are sort of the more sort of use, choose, do's theme here of what really could have prevented us from scaling up in the market. And the scale jokes just write themselves, so I don't even notice them anymore. I apologize if I keep making them. The choose for these patients, right, is their physician. The physician is guiding the patient. A lot of times we like to, or at least, the medical system likes to think that it's making recommendations to patients about how to engage in weight loss. And that's going to vary widely, we know, from physician to physicians in their training and their expertise in what needs to happen. But when we went and started talking to health systems about the role that obesity plays in the comorbid conditions of their patients and why they needed to be aware of it, and how this was a tool that their providers could prescribe to patients or recommend to patients, what we didn't appreciate was that to do that would require entirely different workflows. And so I think we've seen some research. In fact, my co-founder, Gary Bennett, has done some work on how do you integrate into the workflows of clinics. He does that in the primary care setting, of course. But when we want providers to engage with solutions, we have to think about what the downstream implications of them are. And so one of the things, I can tell you, we hear all the time from providers is, I don't know what to do when a patient walks in and hands me like the output from their fitness wearable, which is what we used to hear, years ago, right? Like, I don't know how to process that data. I don't know what I'm looking for. I've got, 11 minutes and shrinking in this office encounter. And so a patient walking into the doctor's office and saying, here are my weights from the last 6 months is not helpful. What the doctor needed from us was a set of insights on what to do with that information and what it meant. And then they might be willing to engage on it. But that has to escalate up through their healthcare system to the CTO and the CIO and create all of these integrations of our data and their data together. And what I heard from their leadership was not, I don't think obesity is a problem. They all knew obesity is a problem in their patient population. It wasn't that they didn't appreciate that obesity touched so many other chronic conditions. It was, I have a limited bandwidth, and my team, we all have limited bandwidth. And this isn't the problem that keeps the CEO up at night for our hospital. For those of you who don't know, the thing that keeps the CEO up at night is typically readmissions. But which isn't to say that they're not willing to tackle other problems, but by not appreciating the implications of our solution into the workflows that existed and how our technology was going to integrate or not with existing technologies in the system, we didn't necessarily appreciate like how difficult it would be and how much had to change for our solution to not lead to a staff or technology burden for that healthcare system. So it's now why I become a big fan of using APIs to integrate solutions and technology, but that's a whole other conversation. On the dues piece is the health insurance company, right? So figuring out who's going to pay for it is a really important piece of this. And I think often underappreciated is that in many cases, for a lot of Americans who are employed, your insurance comes from your employer, and self-insured employers make a lot of the plan decisions that are executed by an insurance company. And so there's a complex interplay here around who's the decider on the dues question. And again, it's not that folks don't understand the role that obesity played or that they don't think it's a problem. But I can tell you, what I heard point blank from an insurance company executive, which was that, the ROI for weight loss, we know happens at 24 to 36 months, which, newsflash means insurance company executive is reading the scientific research around the ROI for weight loss, which thrilled me. But the typical person is on their plan for 18 to 24 months. And that means that they're not going to realize ROI is return on investment, for those of you who don't know. The financial benefit of investing in this weight management program is actually going to pay out after they're on someone else's insurance plan. And so making sure that you understand the pain points, right, the problems and where the wins are for those people is just as important in getting your solution out into the world as it is understanding the pain points for the patient. And that's probably why companies like Omada have been quite successful in taking an evidence-based program like the DPP, getting it out into the world, as they focused on the patient population, those with prediabetes, who have an ROI period that's a little bit shorter. And so thinking about all of those groups ends up being important. So if we kind of come back to what is called the value proposition canvas, and we looked at the right side of this before, you actually need to be thinking about the pains, the gains, and the jobs to be done for your users, your choosers, and your doozers, which is not Fraggle Rock reference, but spends the next 2 weeks singing a theme song can let me know, because now it's going to be in my head too. And then what we want to do is map our hypothesized solution, our prototype, what we're thinking works, the features and functions. We map them to the pains and the gains and the jobs to be done for each of our 3 user groups. And that allows us to really think about, are we solving need to haves or nice to haves? Are we meeting the pain points of all of our user groups or just one? And allows us to think a little bit more about where our solution might fit and what might keep it from being successful in the research lab, but not successful out in the real world. And so there are 3 elements of kind of fit that we think about there. So problem solution fit is the kind of user focused one, right? Like, does your solution work, solve a problem that your patients care about, right? Is it's solving a pain, a gain, or a job to be done? And our product market fit, which is the one the commercial world focuses on a lot, is your solution creating value for people who buy it, right? This is the ROI piece. But business model fit is the last one. And that is, can you deliver this solution in a scalable and sustainable way? And so the way that I kind of frame this up is that we might be willing to make certain trade-offs. Trade-offs are inevitable in any solution that we develop. We can't do it all. We can't boil the ocean, much as I have tried many times in my career, right? So we might be willing to accept a solution that is 80% effective if we can deliver it at 20% of the cost, right? Classic Pareto principle. And a lot of times, we see that in weight loss solutions, right? So we know that the DPP can deliver 6% weight loss, but we know that 3% weight loss is clinically meaningful. So if I can deliver 3% weight loss for 20% of the cost of the DPP, I can deliver it to a lot more people and still have a clinically meaningful effect, right? That's the Rose model, right? So classic Rose public health model is when we shift the whole distribution, we have a bigger effect than if we just focus on one of the tails. And so when we can deliver something at a much lower cost and achieve still some benefit, that's classic public health. And we want to be aware of that trade-off. And consciously, we might be willing to make it in some cases. There might be scenarios where that trade-off doesn't play out. And I think that's the conversation we're having a lot right now around mental health needs, right? So when we scale back on what we deliver and move to something that isn't the cognitive behavioral therapy and traditional models that we know work, are we still delivering an outcome that has a clinically meaningful benefit? Or are we delivering a placebo that does not have a benefit? And this is really where being clear on the assumptions that we're making and anchoring those on the trade-offs that we're making and having the data to support that really plays in. So I know we started late and I want to make sure we have time for questions. So I think I'm going to stop there, Sherry, and let you, I think you said you're going to pull
I do.
questions in for me.
Awesome. Yes, we've got some questions submitted in advance. And some questions from today. So let's see, where should we start? So one question, do you have any thoughts on where technologies could live outside of the healthcare system, such as community, nonprofit, and or public health settings? They can be very fragmented, so this brings up challenges, and who would pay the dues in those types of settings? Any thoughts about that?
Yeah, so I think one of the places that when I was a public health researcher in academia that I did not appreciate the role that they played is the self-insured employer. And so those of you who have worked, unlike me, who went from grad school right through, right? When you work at companies, you might have like an employee wellness program. And depending on or access to an EAP, right? So depending on if we're talking about physical health or mental health solutions, different companies are investing in different ways in the well-being of their employees. And those companies have an interest, both financially and ethically, in delivering solutions that work. And so they are looking for information that helps them deliver solutions at scale. But one of the challenges that those companies have, so I worked at one of them, is we were in 50 states. We served companies that had 100 employees and companies that had hundreds of thousands of employees. We had to serve the needs of the person on the factory floor who didn't have a company computer, as well as the CEO. And so when you're trying to deliver a solution to that diverse an audience, you are going to make trade-offs, right? You may not be delivering the best-in-class solution. And so it's a tension, I think, that we navigate, because a lot of our at least from my experience when I was in academics and doing research, is a lot of our research is focused on optimizing things that already work. And sometimes in the commercial world, one of the challenges to getting things out there and to scale is actually to go in a different direction, which is, how can I take this kitchen sink and pare it down to its essential ingredients to deliver it at a much lower cost or much greater scalability.
Awesome. Okay, so next question. A lot of behavioral scientists and public health scientists are trained in ways that they don't have experience in clinical settings. So what one or two courses do you think such graduate students should take, or experiences they should get, to sort of understand the systems in which they might be thinking about designing tech for?
Well, I mean, so the behavioral scientists that I trained with are all training in health behavioral science. So they're all having some kind of clinical conversation in their work. I recognize that behavioral scientist is a term used much more broadly in some settings, and there may be people who've never read a PubMed paper or had that experience. And so I think that, understanding sort of basic public health if you are coming out of maybe a economics training, can be helpful to just understand how those systems work. I think this is also a place where diverse teams matter. So if you are building a solution and no one on your team has worked in a hospital, I would suggest that you rethink your team. And I think, similarly, like if you are going to be building a solution for healthcare where the randomized controlled trial, for better or worse, is the standard of evidence, and someone on your team, even if it's an advisor, has not conducted a peer-reviewed randomized clinical trial in a healthcare setting, that expertise and knowledge is really, really helpful. I wouldn't go in and design a solution to be used in a surgery setting without having a surgeon on my team. Like it was, sort of just, that's part of the training for those of us who came up in health behavior science, is that we had to work on those teams. I had to have mentors. And so I think if coursework is really important, and as an ex-academic, I don't want to diminish it, but, get those people on your team and then listen to them.
I think that's great advice, because obviously we can only get so many experiences as we're being trained. And that's where the team comes in. I feel like in my career, that's been so invaluable too. Because for a while when I was junior, I was like, oh, I need to learn that and I need to learn that. And there's so much I don't know. I'm going to be in training forever. And then at some point I was like, oh, wow, I have a collaborator who knows all of that. So I'm just going to leave it to them they can handle that. And then I can just do what I do best. And so that
totally. And
stress went away.
And learn by doing. Yeah.
Mm-hmm.
Right? We learn by doing. So, I think one of the, I worked through grad school out of financial necessity, but I learned as much in the part-time jobs that I had through grad school as I did in the classroom. All due respect to the teachers who taught my classes.
Awesome. I see we're at 1. I know we have a couple more questions, but maybe I'll send you the link to the YouTube and you can type them in so we can let you get back to your day. And I have some listed here, so I'll enter them in the YouTube. But thanks everyone for joining. And thank you so much, Dr. Wolin. This was an amazing talk as always. Excited to share the link with my class. We're going to watch it as a class assignment. And so, yes.
More dad jokes for you
back, because we always do. Yes,
Thanks,
Dr. Kate Wolin on Twitter.